of the end-of-life issues. And then what I'm going to do is towards the end, I've added some different slides to kind of update what's going on nowadays and where we're standing and what some of the big issues are, because I think people don't realize, you know, if you're not in medicine and you don't have somebody to advocate for you, you don't understand what they're saying by some of these forms, and then it's kind of hard to discern what should you do, what's the best course for you and your family, but you also have to think of, in light of the church's teaching, what should we do as good Christians, good Catholic Christians, you know, to honor the dignity of the human person. So at all stages of life, especially, you know, the beginning and in the end when people are more vulnerable. So we start off, we're talking about the advanced directives, the living will. This is something that a lot of people have heard about, you know, what are we going to do at the end of life? So this is something that some people have different mixed emotions on, whether, you know, what am I doing and who's taking care of me? What is the person's request? What do they want to do? You know, okay, my father's really ill, my mom's really ill, my grandparents, and, well, what do they want? What do they want? We have to think about what the church's teachings too. So we have to let them know, you know, what's the right thing to do. Let's give them basic kind of care. This was an interesting story that you put on there, and I left it on here because it was a woman who had tattooed right on her chest, "Do not resuscitate." So she was a nurse, and so that's the DNR, do not resuscitate. She was a nurse, just started, and she wanted to make sure that people knew what her wishes were. Nowadays, I guess, it's a little different because there's so many other things out there trying to say, you want IV, you want no IV, you want antibiotics, you want this, you want that. That's going to be a lot of tattoos, right? So there's other ways to do it, so that's what we're trying to talk about today. Her thing was that this was around the time with all the Terry Schiavo, controversy, and so she decided she's going to make sure everybody knows what she thinks, just in case she's incapacitated. So the advanced directives in New York State, we have the 3 forms. We have the living will. We have, that's just your instructions, kind of if you spell out. The problem with that is, you know, you don't know what's going to happen to you. You don't know if it's that you have a stroke. You don't know if something's wrong with your intestines. So it's kind of hard to anticipate what your choices are going to be when you don't know all the possibilities. The healthcare proxy, which that's probably one of the best options to do. If you have a healthcare proxy, somebody who knows you really well, who knows what the church's teachings are, will follow that for you in case something comes up that you didn't anticipate. But they know that you're going to want to do things, you know, that are going to be in line with the church and what your wishes are. The healthcare proxy supposedly takes effect if 2 doctors say that you can't decide, and sometimes they will, decide for you. So it's good to have a healthcare proxy on your own, which is it's kind of like having a power of attorney. That person then can act for you. And then the DNR, do not resuscitate. So those are the 3 advanced directives. There's also, DNI, which is do not intubate, but that falls under other umbrellas. So if we look back in time, actually in 1967, which I hadn't even realized that it was that early that people were talking about the rights of the dying person. So, can they choose what they're going to do? Can they choose their decisions they're making at the end of life? 1968 was the first time that the legislation was introduced by a physician and legislator. Fortunately, it was defeated at that time. 1972, this was introduced in California, which is one of the first states that has passed the euthanasia and physician-assisted suicide. And we'll talk about that in a little bit. His thing was that he felt his mother-in-law's wishes were being ignored. It was defeated, but then in June 1976, was the big case with Carrie Ann So, you remember, she was a young girl, 21 years old, fell into a coma, and then ended up in a persistent vegetative state. So the parents had wanted to take her off of the respirator. The doctors at that time were like, no, this is how we're gonna keep her alive, so they didn't want to take her off. So then there was this whole big battle, and went to the Supreme Court in '76. So in '76, September, in California, they finally signed for the Natural Death Act to withhold or withdraw life-sustaining treatment in patients who are terminal or permanent unconscious condition. So of course, you know, once one gets started, you have the domino effect, and then of course more and more states were involved. So 1977, 43 states had considered it, with 7 passing. 1991, there was just a act saying it should be the patient determining it on their own. What are their wishes as far as advance directives for the end of life? By 1992, all 50 states and the District of Columbia have some form of advance directive. This is all being changed now, so it's just kind of snowballing. So presently we have maybe 4 out of 5 who do not have an advance directive. So 85% of Americans die in a healthcare setting. 12% die in an intensive care unit. But you have to remember that when you're most ill, that's where you're going to end up being, right, in the intensive care unit. The living will, the problem with the living will is it's more a withdrawing support. Let's not do this, not do that, not do the whatever, versus what can we do. So it's more of a withdrawing than providing care. So mostly it's going to say, you know, do we want to stop feeds, not do a G-tube, whatever, and or stopping a respirator. So where did a lot of this come from? I think that a lot of the government costs here, you know, thinking about public spending and how much is the healthcare cost is kind of skyrocketing. So they're saying that the last 6 weeks of life is when you're going to get most of your healthcare, which is true. You know, you're trying to take care of whatever is ailing you at that time. So they're trying to look at the costs and how could we use our healthcare dollars more wisely. Sometimes it's people's fear. A lot of people are saying, you know, well, I don't wanna end up in a coma. If I'm gonna be a vegetable, I don't wanna be, you know, just, you know, unplug me, right? But how many people say that? So there was a lot of this issue when the whole Terry Schiavo case came up. So she had cardiac arrest. And then she was 7 years it was a 7-year battle, but she was several years in a persistent vegetative state. So the husband had been fighting with the parents and who's going to win as far as DCing all her life support. I can't remember exactly, but I remember somehow way back in my brain somewhere that when they said she would have no food and water and she was receiving just Eucharist, I think she had lived like 13 days with just the host. No water, no food, just the host. But then the husband stopped that too. And then that's when she passed away. So the other thing is we think of, you know, we're kind of projecting our fears on somebody else. So, you know, we think, oh, well, they'd be better off dead, you know, just what are we thinking versus, you know, what's the right thing to do. And the whole thing with this, what kind of quality of life are we having? You know, that's where the issue comes from. What's the quality of life? But every human person has dignity. It doesn't matter what their quality of life is, right? So some people think, okay, well, I'm going to relieve them of their suffering. So, you know, there's different things that kind of tell us, you know, different people have different beliefs as to what is suffering, what constitutes suffering, right? And then, of course, people think, okay, well, I'm honoring their choice. The problem thing that's kind of propelled things into where they are now. So, Great Britain, Canada, you know, their health system is all more rational care. So people in Canada, if they can't get, you know, dialysis, or if they have kidney stones, can't get them treated because they're rationed, you know, if you're a certain age, sorry, you can't get that kind of treatment, it's too expensive. So they'll actually come across the border and seek treatment here. I remember when I was a medical student and finding out there was somebody who was coming across the border to get kidney stones, lithotripsy, where they have a radiation to break them up, sonogram or whatever to break them up. And I'm thinking, why are they coming here? It's like, well, because they can't get the treatment there. That's kind of interesting. So Oregon had a health plan that was set up, which is similar to our Medicaid program. And so what they did is they're saying that they're making the health care available to the working poor who can't afford to get insurance, but they said, well, then but they won't get any prescription coverage. So it's like you're saying you're going to take care of them, but yet, you know, scripts are very expensive. So it's kind of rationing out and trying to keep costs low. So one of the governors had said, the elderly and very ill have the duty to die if the patients are suffering beyond the ability for us to help. We've got a duty to die and get out of the way with all of the machines and artificial hearts and everything else like that, and let the other society, our kids, build a reasonable life. So this is the thing where people get this, they hear this in the news, and they get this idea of, oh, well, I'm going to be, you know, a burden to people, and we have to just get out of the way. But life is more important to that. This is a woman in Oregon, which is one of the first states to have the euthanasia and physician-assisted suicide, but she was part of the problem with the Oregon health plan. So she couldn't afford regular insurance, so she had to have this insurance, and she needed chemotherapy, but they won't give her any prescriptions. So your chemotherapy was considered a prescription. But they would cover her to get a lethal dose of medication to just end her life. So it's something that people are not realizing what it is. So when you look at causes of mortality in a nursing home population, when you look at DNR, which is something that is prevalent in nursing home situations as well as in the hospital. So this was a study that was done, it was in the Journal of Geriatrics. So they looked at nursing home patients, 1,600 residents. They looked at the DNRs and how people who are admitted to the nursing homes and signing these DNRs, how that's been increasing. So it went from 12% to 37%, so more than double, almost triple. So the DNR had care limited beyond holding of CPR. So DNR is supposed to mean, if my heart stops, I'm not going to be resuscitated. You're not going to try to get my heart going again, right? That's all it's supposed to mean. But it ends up being that the medical community sometimes will look at it, or the staff, the family, whatever, well, they're DNR, that means they're ready to die. It's like, no, that's not what that means, right? So sometimes the care for the patient is being withheld. So then these patients who are getting less aggressive care, right, had an increase in mortality. So the less treatment they were getting, the more deaths they were having. So that the more DNRs they had, the more deaths they were having. So should it affect the quality of care? Just because you say, if my heart stops naturally, that I don't want to resuscitate it, just, you know, it's my time to go, it's my time to go, fine. But should that mean you don't get good quality care? For the patients who had the DNR orders written during the hospitalization, the in-hospital mortality rates were higher for the patients who had a DNR versus patients who did not. So without the DNR,
Makes sense.
huh?
I said that makes sense.
Yeah, well, 40% of them, there was a higher mortality, so 40% versus just the 2%. So then there was a study that was looking at if you have a certain case scenario and you tell the physicians, okay, these are the patient cases, this is the scenario, what's going on, and then you say patient has a DNR or does not have a DNR. With the DNR, so those who had the DNR, fewer interventions were being done. So in other words, if somebody was sick, had a fever, and you're trying to do a blood culture, so they take a little bit of blood to find out, is there a bacteria in there, and what's the best antibiotic for that bacteria? They were not getting the blood cultures. They were getting less ICU care, fewer intubations, fewer CVP lines. The line, that's just to, it's into your main vessel so you can see what your pressure is to see if your heart's getting enough blood. So they weren't getting transfusions. So it's not held to just do not resuscitate. It's kind of expanded so that it is less care. So they looked at DNR on nursing home patients too. So there was 36 nursing homes, 4,000 residents. 60% had DNR, and some of them had DNH, which is do not hospitalize. So if I'm sick, just treat me here in the nursing home, don't transport me. So after controlling for confounding, they looked at the likelihood of a hospitalization with a lower respiratory infection. So that means that pneumonia. So if somebody is sick in a nursing home and they get pneumonia, right, it's in their chest, would they be more likely to get the care, get sent to the hospital? Where would it be if they have this DNR? So the residents who had the DNR were less likely to be hospitalized. So is the DNR functioning as a marker for care limitations that's not related at all to resuscitation? Sex differences in DNR. They looked at the study to say if there's emergency surgery and patients need to be admitted to surgical intensive care. They looked at the DNRs, and if there was, they would get it more for the women than they would for the men. I don't know why. Because they hear the women live longer than the men generally. I don't know. Oh, well, one thing I wanted to say about that was, of the 92 patients who were made DNR, 82% of them had passed away. So it's really less care in general. So, supposedly, right, your DNR is not to impact your mortality. But if they looked at different ICU things, patients, 50% who had DNR died versus 25% who did not have DNR. So that's double, right? And that's only in a 60-day period. But as the time went on, that there was more and more, that difference was larger and larger. So they got less assessments, there's less doctor's orders, there's less testing, less interventions done, versus just DNR. This was a seminar. Dr. Toffler is a family practice physician in Oregon, and so there's a society for the teachers of family medicine, because he works at the university hospital, so he does a lot of teaching of residents and students. So he went to this talk, and he said it was interesting that they started talking about residential facilities and how the goal is to have 100% of the residents in nursing homes have a DNR or DNI or some kind of advanced orders in place. 100%, that's their goal. So they've been really working on that. And so what they said is, don't revisit the orders because, they might change their mind. So just, get them to sign it and then don't look at it again. And then they announced that the residents live an average of 17 months, which is down from 26 months. So they're dying more earlier because there's less care being done, right? But there's a savings of $100,000 per resident. Like, okay, what's more important, the person or the, you know, the saving? So it's the paradigm switch there is heartbreaking. So now we're looking more at physician-assisted suicide and euthanasia. With this is that the regulations are that for euthanasia, physician-assisted suicide, the patient has to be terminal. They're not expected to live more than 6 months. The problem is that when people are depressed, they want to die. Sometimes they want to die. And they might say that, and then tomorrow they're fine. But the problem is if they say that and somebody writes down what they say, then boom, that's an order. You know, so we have to really be more conscious as to what they're feeling and what are their real needs. You know? This is just a graph where he was talking about people's perception of pain, right? So if you say, okay, you know, if I have cancer and it's in all of my bones and I'm in a lot of pain, well then just get rid of me. I don't want to live like that, right? People will say that. But the people who say, give me the euthanasia, right, when I'm in a lot of pain, they don't have any pain. They're saying that when they have no pain. But when they have pain and you ask them, no, I'm okay, just give me my pain pill, I'm fine, right? So their desire to have euthanasia is not really just to the pain they're feeling, is just their thinking, their belief that, okay, when I'm in pain, I don't think I can handle it. But actually, when they're having pain, you take care of their pain, they're fine. They don't want, so that there's really an inverse relationship there. So now, why should we care about this? Because change happens, and guess what? It's really happening now. Fears resolve, so some of the people who are afraid of what might be happening, it's not going to come to be to what they think it is. Their perceptions are flawed, right? Their motives mixed. That's a scary thing when you say, you know, a person says, I want to die, but maybe they just say I'm useless, or they're saying I don't want to be a burden, but maybe somebody's saying, am I a burden to you? Or I don't want to be on a respirator, but they're saying, you know, I'm afraid of losing control. Or somebody says, I've lived a long life. Maybe they're just tired, feel like they can't keep going. Or somebody who says, I might as well be dead. But maybe that's because nobody's called them in a while. They're just feeling like my family forgot about me and they don't care about me. You know, and those are temporary things. So this is one of the first women who actually did the euthanasia in Oregon. So she had lung cancer, had been smoking since age 19. She was 62 years old. So because of the death with dignity, she was able to get a prescription for a lethal overdose, and she decided to have a goodbye party with her friends, and then just take her meds and be done with it. That was the end of her life. There was another case that, because the medical records of people are protected, so a lot of the things that are going on, you know, we don't really know about it publicly. But this man had lung cancer, recurrent depression. He had called Dr. Toffler's group, which is PCCEF, Physicians for Compassionate Caring Education Foundation. And so he called them thinking compassionate doctors means death with dignity doctors. And so they had met with him and they found out, you know, about his depression and were helping him kind of get through his issues. So they treated his depression, they were helping him with his pain control. Now he had gotten this prescription from this doctor, but he wasn't terminally ill. He wasn't at that stage where he only had 6 months to live. So during the hospital visit, somebody did a home visit and they found that he had all these different weapons in his home. It was just very disheveled. The police came, they removed the weapons, but they left the overdose that was there of the drugs. So even though these are, you know, narcotics, that they just left it there so that he could whatever. But it was 2 years after that he actually passed away from his disease. So it was almost 3 years since the first time he got that prescription. So the problem with this is that nobody is monitoring what's going on. And when they passed that law that they said you can write this physician-assisted suicide, these lethal overdoses, that physician is not held liable. They're not accountable. So they can write these scripts for whoever's asking for them. They don't have to follow the guidelines, but nobody's making sure that it's being done correctly. This is Dr. Toffler. I just wanted to say something about him. He started that organization. He actually is a perfect example of what he's talking about here, because this article, he was talking about how his parents moved into his house, and they were taking care of his parents at the end of life. Then his wife's parents got sick, and they moved in, and they were taking care of his wife's parents. And then his wife ended up with cancer. And one of the things he was saying with her was that she had, the cancer was uterine, but it had spread to her spine. So she was having horrific pain because it was pinching on the nerve. So they wanted to have surgery to get that removed so that she gets some relief. So it was more for pain relief, right? Palliative care. Not to cure her. They know it's not going to cure her. But they had a hard time finding a doctor to do the surgery because they kept saying, well, you're going to be gone in a few months anyway. So why should we spend the money and the time, whatever. They found a doctor who was willing to take care of that. So they removed that lesion that was pushing on her nerves. She actually was able to function a little bit better, and she attended her son's college graduation. So that was for both. She knew that she wasn't going to be around for long, but she wanted that for her son. So she said that surgery, yes, it wasn't going to cure me, I know that, but it's going to give me the time I need that I can at least do this and be there for my son's graduation. So that's Dr. Toffler and his family. I think he has seven children, grandchildren. So now there's another case that in the Catholic Medical Association, we have a little journal, and there was an article there by Dr. Callahan. So his mother got very sick. She was septic. She had C. diff colitis. So this bacteria had kind of gotten right through her blood, and so she went into the hospital sick. And when they first saw her, sometimes a lot of things can present similarly. So are they in shock because of infection? Are they in shock because their hearts, their failure's low? So she got a lot of IV fluid when she first came in, and then they found out that, she was septic. They gave her the antibiotics, but she had too much fluid, so then she had trouble breathing. So because she was 83 years old and her white count was 59,000, very tremendously high, they advised to just let her go. And so the doctor had a fight for his mom, and he says, listen, I know that if you intubate her for 4 days, just to get the fluid off, get time for her lungs, to help her lungs, while she's got all this extra fluid, we get rid of that fluid and take care of her, I know she's going to be fine. So he had to fight with them, to advocate for her. And so they did that, and then she ended up in rehab for 30 days, and then 6 years later, she's still doing fine. So here's a woman that they were trying to end her life at 83, where, God said, no, she could be around a little bit longer. So it was kind of a cute thing where he says, not every old person who's acutely ill is like Humpty Dumpty, never to be put back together again. It's if you know people, I've had certain friends. My mom passed away in 2014, my husband's dad. We've had other people in our family and people that we know that have lost parents, and a lot of it is, just really limiting care. So this I kind of touched on a little bit, that the euthanasia stuff is supposed to be physician-assisted suicide. It's supposed to be for those who are terminally ill, not expected to live greater than 6 months, those who are mentally competent, meaning that you don't have any mental illness, you're not depressed, you're in your right frame of mind to make that decision if that's what you want. The death with dignity doctors are not being regulated, so no one's monitoring what they're doing. So most people probably remember this, which was pretty recent. Brittany Maynard in 2014. She said she had terminal brain cancer, 29 years old, and said, I'm going to go to Oregon because I want to have physician-assisted suicide. I don't want to, to live with this problem. This is somebody who is totally opposite from that. I'm going to try to get this to work.
I feel like I'm a little girl at a party whose dad's asking him really early, and I'm throwing a fit. I'm not afraid of coming. I just don't want to go. My name is Kara Tippett. I'm 38 years old. I have 4 amazing children and 1 excellent husband. And I've been battling cancer for the last 2.5 years.
The last 2 years have been very stressful. Now having her enter hospice and thinking through what it's going to be like to live life without her.
Kara is.
Kara before cancer was.
Yeah, I memorized
Was
that.
ambitious and amazing and...
No, I answered.
Okay,
No,
I was helping you.
She's always been very beautiful to me. Her fun personality. She always loved whoever was in front of her.
You're talking about me in the past tense.
My mom's hair fell out because of chemo, I think.
I had really long, beautiful blonde hair, and I didn't realize how valuable it was to who I was until I lost it. It made me shy in a way I'd never been shy. And who am I without hair, without breast, without uterus? Do I still have value?
This is not supposed to be the story.
You're doing great. Even though you're sick.
The world says I should be angry, that I should be shaking my fist at God. But I want to be able to share the story that suffering isn't a mistake, and it isn't the absence of God's goodness. Because He's present in pain.
My mom has cancer and she's had it for a while, and now she's gonna have it for the rest of her life.
In the beginning, we just decided to speak honestly and frankly with the kids, not give them too much that their age can't bear. But all of them now know that Mom's dying and that I have cancer.
I don't need to go.
We all want more time. We all pray for more time.
Seeing her give back to people and to write her book has inspired me. She showed me what love is.
I don't want her to leave. I don't want her kids to be without her. I don't want Jason to be without her. I don't want this world to be without her.
Jason shows me the best of what life has to offer, mostly in encouraging me to fight for a soft heart. I know I've got cancer. I know I'm going to die of it. But I also know that I have today, and in this today, I get to live well.
So, where are we now as far as, let me get this back up. Where are we now, 2016? 5 states that currently have physician-assisted suicide. Oregon, California, Montana, Washington, and Vermont. New York State and Connecticut have it in Congress now. There's a bill now that they're waiting to pass. I actually just got a thing in my email. We need to write to our legislators and let them know we do not want this to pass. The bill is actually called the New York End-of-Life Options Act. So, but that's really just physician-assisted suicide, right? The fear is, at least my fear is, that just like this whole controversy with, you know, if you don't give us what we want, we're going to sue you. So those doctors who are handing out the meds, they're protected. But if I decide, because of my conscience, I don't want to write them, I'm not protected. I could end up in jail, right? So that's why we need to make a stand, make a statement, let them know that we do not want these bills to pass. So, end of life, what does that mean? We need to intensify our caring. We need to intensify our contact with people, making sure they don't feel alone, making them comfortable. Yes, we are not going to cure, but we can still help them. You know, we're not meant to be alone. We're supposed to be together with other people. He was just saying, you know, is there something that instead of DNR we could put IC triple C so that we can intensify caring, contact, and comfort instead of having a DNR on there. So patient choices at the end of life. What do we know? The DNR does affect their care. The content of the request may be not what's the same as the underlying process of what's going on. People change their minds, and they often change their minds. A lot of that depends on how they're feeling. What's the given situation, and you can't anticipate that. You can't look at the future and know what all the different situations are going to be. So, continuing, what about our choices? You know, what's the patient's feelings? What do they really want? What about the health provider, myself and my feelings versus somebody else who might be taking care of somebody? What about if I remember hearing on WLOF one time on the radio, some woman saying that, well, she's the one stuck caring for her grandmother, so why shouldn't there be physician-assisted suicide? You know, she's lived a long life and there's, you know, she can't do anything for herself. So this girl was just complaining because she was kind of bearing all the weight. It was, you know, for her it was a burden, but if there's people to step in and relieve the burden, then, you know, the life will be saved. So some people it's secondary gain. So if my parent dies or somebody dies, and do I get their money? Do I get all their, you know, goods or whatever? So we have to be careful with what's going on. The forms, like I said, it could be biased. This is the other thing that I didn't have it here, but when you are in that situation, and this is what triggered me, is that when my mom got sick, she lived with me for 5 years before she passed away. When she got really sick and we found out that she had cancer and it was all over, I mean, she had had breast cancer probably 10 years before that, but it was in her lungs and her bones, and she had trouble breathing. So we took her to the hospital. She had fluid in her lungs. They did not want to take the fluid out. They said, well, she's dying. There's nothing we can do for her. She's not that long to live. And I'm like, but you can help her breathe. You just put a little needle in there, take the fluid out. And the pulmonary doctor did not want to do it. Said, no, she's dying, we're not going to do anything. So I fought with them, and then the radiologist actually did it. They took out 800 cc's, which is one of those liter bags of fluid that you know, when you get an IV fluid, that was in her lungs. The next day, I mean, she was breathing so hard. The next day after she had that, she was sitting up in the chair, breathing comfortably, talking. She goes, wow, I didn't realize I was so sick. It's like, yeah, well, you were sick. But, you know, we ended up putting her in a nursing home because it was getting harder to take care of her. My husband actually did the brunt of it because I was working more hours. He was home earlier than I was, so, she ended up there, which was a good thing because I'm from a big family, and it allowed other people in the family time to be with her in the nursing home. So she was there, she was never alone. Her fear was to be in a nursing home and somebody would beat her up in the nursing home. I don't know where she got those stories from. But she ended up having one of her children or grandchildren with her 24/7. So she was really the talk of the nursing home floor, that they never had anybody who had somebody with them 24/7. So they did push, and I felt it was a push for us to sign the forms for her to have the physician's orders. And that was the thing that I got into an argument with one of my siblings because I said, no, I know what this means, and I'm not going to agree with that. But the way they presented it is, well, she doesn't want to be a burden to anybody, and she's this and she's that, and it's like, I'm not signing it, I'm sorry, I'll sign DNR, DNI, because I know that's what she wants. I know she doesn't want her heart to be resuscitated, she was 90 at this time. I know she doesn't want to be intubated. She's always said that, she doesn't want to be on a ventilator. So, but I think it was just, of course, so you have to really be aware of what's being said.
But the thing is, if you hadn't pushed for the doctor to remove that fluid, she would have been gone probably in a day or two.
Exactly. So you have to remember, having your forms are okay. That's a good thing. It's a good place to start. If you're having discussions with your family, letting them know, letting your friends know, whoever is around.
I'm sorry, what was that you said that you felt like they were pushing you to?
To sign the most. So there's a DNR and then there's the most. Yeah, I'll talk about that in a second. So at the end of life, you have to look at what's the worth of the person. That Kara Tickert's, it's called The Hardest Piece. God is good. I mean, somebody told me about this book probably about a year and a half, 2 years ago. She actually she has a blog, and she wrote a letter to Brittany Maynard saying that, our life has value. Every single day that God gives us has value. She's not Catholic, so she says God is still with her in her suffering, but we as Catholics know that our suffering, we can unite that to the Lord, and it has redemptive value. So it's not that it's worthless, it has redemptive value. So I have that there for anybody who wanted to look at that. So when you look at, in the old days, we were always trying to cure everybody of everything, we were hitting them with all kinds of things, and, sometimes it was more than what people needed at the time. The ideal now is, let's kind of modify. We can give them care, we can do palliative treatment, but we want to really be caring. We want to be gentle and caring at the end of life. The most is medical orders for life-sustaining treatment. So now instead of just DNR, DNI, they're asking for IV fluids, IV antibiotics, and G-tube. Those are the three main things that I remember. Fortunately, I'm a pediatrician and I don't have to deal with a lot of that stuff and life issues as frequently, but those three things, it's a yes or a no. I want it or I don't want it. I want antibiotics, IV antibiotics, or I don't want IV antibiotics. And I remember them saying at the nursing home something about, well, if she has IV antibiotics, she's going to have to go to the hospital. I go, okay. Oh, well, if she goes to the hospital, we're going to be putting her in pain because we have to transport her to another bed, and then she's going to have to take an ambulance ride, and she's going to be in a lot of pain. And I'm thinking, when you clean her, you're moving her kind of off the bed, same kind of movement. So what's the difference between that and going in the ambulance? I don't see the difference. But I think they were trying to present it as something so that, kind of shock tactic. And what Dr. Toffler had said was that they actually train you how to present that to somebody. And so they use words like, you don't want to be a burden to somebody. You know that they wouldn't want to this, or you know, and it just like kind of puts those thoughts in your head. So you really have to look at what's being said and really, just pray, ask the Lord to guide you to say, what is it that the Lord wants us to do? He wants us to care for people right to the end. And that's his job. When life starts and when life ends, that's his. I always say that, as physicians, we could try to save somebody, and if the Lord's going to take them, no matter what those physicians do, the Lord's going to take that. And the reverse is true. If we think they're going to die, it's like all of a sudden they turn around and they're bounced back, and it's a miracle. Okay, because God is the author of life and death. And so, as
He's driving the bus.
Say that again? He's
driving
driving
the bus. I would say that.
Exactly.
But it's true.
Yep. So it's his decision. So, I think this is just something we need to be aware of. We need to let people know, and hopefully we won't be in this situation ourselves.
We are aware of all these incidents, but what is the church's stand on DNR?
I'm glad you asked, because it reminds me that the Buffalo Diocese came out with this now, our death, well, it's actually from Bishops of New York State. And if you go on the website for the diocese, you can download this. So this talks about the church's teaching, right? And it says that there's active euthanasia and passive euthanasia. So withholding the care is considered passive euthanasia. Taking pills to make yourself die, that's active euthanasia. So it goes through all these different types of things. Talks about the nutrition and hydration, right? Because in some situations, yes, you want to give them fluids. Maybe you want to give them, or like that intubation in that example, just for a couple of days to help them through a little time. And that's the question is, where are they, and so there's a varying degrees to what people need, but it goes through all different situations in there. And then at the end, it does have a little healthcare proxy form too. So if you wanted to do one, you can do one. So you can just go on their website and.
In that pamphlet, is there any information on hospice or hospice? What is the role of hospice?
I don't think it talks about the most, talks about the DNR and talks about the most, but it doesn't really say about hospice. Now you're going to remember hospice is more about compassionate care, right? So you have the one thing about hospice you have to be careful with too is it is trying to make the patient more comfortable, right? But they do have cost limitations, things like that too. So, for example, when my mom was sick, her breast cancer had been spreading, and that's what caused the fluid to build up in her lungs. So she saw the oncologist, who said that we can put her on this medication to stop some of that fluid from building up. So then hopefully it won't happen right away, because a lot of people have to get that draining done several times. So then when we went to put her in hospice at the nursing home, they said to us that, oh, well, that medicine's not covered. And I said, well, then she's not going in hospice, because I'm going to make her comfortable. She says, well, that's a cancer, it's a chemo drug. And I said, well, we're not using it to cure her. We know it's not going to cure her. We're using it to make her comfortable so she doesn't get the fluid. So there was a big fight about that, and that was another thing. My sibling and I were fighting, where I said to her, listen, people have died for centuries without hospice. If they don't want to give her this medication, then she's not going to hospice. She can still go in a nursing home without hospice. I don't want to limit what we do to make her comfortable. So then they went through some other, some board member, something, but they got it approved that she could get the medication. So that's where you have to kind of be aware and be an advocate, you know, and if you know people, you can ask, you know, just to ask people to help guide you when you're into a situation that you're not sure. So, I think you can get these online too as a booklet, but I know that they do have it on the website so that you can just download a healthcare proxy form, and that's what you want. Thank you so much for coming.